So what is a genetic counselor? I'd probably say at least half of this room probably works directly with a genetic counselor, or at least referred patients to see a genetic counselor. But in general, genetic counselors are, we're very specialized in training. Currently, to become a board certified genetic counselor, you do have to attend a certified master's level training program. There's approximately 25 training programs in the United States. And we do have board certification by the American Board of Genetic Counseling, and more states are obtaining state licensure, although that has been quite an uphill battle. And I work in Michigan, and we currently do not have state licensure. The difference between a board certified genetic counselor and some others who may purport themselves to be a genetic counselor is the level of training and the amount of training and the continuing education. And so I would say you just need to be careful if you are making a referral to make sure your patient's getting to see the most appropriately trained individual. Genetic counseling is a process, a communication process. An amazing amount of time is spent before we see a patient, while we see a patient, after we see a patient, a year after, 2 years after, et cetera. We are pretty intimately involved with our patients and their families. We do extensive collection and interpretation of family medical history, and just FYI, Thanksgiving is National Family History Day, and we do encourage you to sit down at Thanksgiving dinner and just have a little chat with people. What's going on? People think that's a weird thing to do, but usually there's alcohol involved, so perhaps this is the time to ask the question. We do a lot of education with our patients and families about inheritance. What does that mean? How do you get something from mom or dad, or skip a generation? Maybe we need to talk about that a little bit further. Testing, what does testing mean? What can it tell you? What can't it tell you? Management, prevention, resources, research. We are intimately involved in all these different areas. So we have a lot to offer patients, and we usually have a lot of time in which to do it. And then certainly we promote informed choices. My training was quite a while ago. And we were very much of the mindset at that time to be non-directive. I would say genetic counselors are less non-directive, a little more directive, but still very importantly promoting patient choice. But it's usually very clear to us when a patient's making an uninformed choice, and we can tease out, so why did you make that decision? And then a lot of times the misconceptions come out, and we can help them maybe reassess their choice if necessary. So genetic counselors do have a unique skill set. John and I both have had the pleasure of teaching epidemiology at MSU Medical School, which is not rainbows and unicorns, as you all know, but that's a skill set that we as counselors are trained to do, is to analyze data, look at data, apply data. We obviously have counseling skills, as I like to call the touchy-feely side of data. And then we have a very unique network of providers. The most strange things will come up, and I go, I know somebody that specializes in that. So we can tap into each other, because currently there's only about 3,000 board-certified genetic counselors in the United States, and we pretty much all know each other. So my role at Priority Health is a little different than your classic clinical genetic counselor. I did clinical genetic counseling for approximately 15 years before I switched over to managed care. And at Priority Health, one of my main responsibilities is the development and review of medical policies. So it's not just genetics that I'm involved in. It's whatever is necessary, whatever we need. And one of the more recent policies we developed was on sinuplasty. Why is a genetic counselor writing a policy on sinuplasty? Because it's the same skill set. I know how to review data, I know how to look at the evidence, and I can come up with a policy. So that's a nice thing about the background of a genetic counselor is just our general skill sets. I do work with the medical directors on clinical review, and primarily that is reviewing genetic cases, and we are getting inundated with requests for full genome sequencing, exome sequencing, mitochondrial sequencing, and now panel sequencing for all the various cancer syndromes. And so it's my responsibility to review those cases to make sure that the information submitted fits the purpose of the test and that the results of the test potentially will have impact on care. We evaluate new technologies, and probably the most enjoyable, I shouldn't say the most, one of the most enjoyable aspects of my job is working on the grievance committees for both our commercial products as well as our government products, Medicare and Medicaid, which sounds odd, but the reason I enjoy it so much is it's those outlier cases that brings to our attention things we might have missed during the normal processing of how we view any one particular problem. So it helps us realize, are we doing the right thing? Yes, we're doing the right thing. Or, you know what? Maybe we're not doing the right thing, and we need to make some adjustments in our policies. And then also I help answer provider and member questions specifically regarding genetic testing. So if a provider's not sure what test to order, or if I'm not sure what test they're ordering, I can pick up the phone and give them a call, and I have probably a little more background to ask some questions that maybe potentially I'm not, no slam against medical directors, but you just might not know the right question to ask when it comes to genetic testing. So why hire a genetic counselor to do this? I have already elucidated what I feel those reasons are, and I'm not trying to promote payers in the audience to hire a genetic counselor to do what I do, but I think it can be advantageous to have someone on your team looking at these issues. So what is driving the explosion, literal explosion of genetic testing? Certainly completion of the Human Genome Project was a big step, but now we're going above and beyond that. Array analysis, every day I get requests for array analysis for a variety of indications. Identification of correlation of phenotypic disease with genotypic expression. You know, before we could look at cystic fibrosis and say, hey, there's about 400 different changes in the CFTR gene that can lead to the development of cystic fibrosis. Well, now we have been able to characterize not all, but a fair number of those mutations and how those mutations may interact with one another in expression and help guide us for treatment. And that's definitely translating into other areas of disease. Most of you are very well aware of potential of personalized medicine, looking at various tumor markers and knowing, well, an individual that has this mutation is not going to respond well to treatment A, and therefore we need to try treatment B instead. Individuals want to know this information. It's everywhere. I don't know a TV program out there that in some way, shape, or form hasn't used genetics or testing or something in their plot line. And another big driver of genetic testing is profit. If for those of you who were at Ellen's talk last night, you look at the explosion of labs offering BRCA testing since July, it's amazing. But I look at that list and I see names on there that I'm like, no idea who these labs are, what their background is. So it's frightening. It's frightening to try to pick and choose a lab that you know you're going to get a result that's clinically valid. So some of the projects that we've been working on at Priority Health are collaborative agreements with the CDC as well as the Michigan Department of Community Health. And genomics is one of the newest areas that have been added to the Healthy People 2020 project. And the goal is to improve health and prevent harm through valid and useful genomic tools in public health practices. The trick, though, with genetics, as you well know, it's very hard to come up with what we would call Category 1 or A-level evidence on any one certain test as far as how it's going to change or improve outcomes. However, USPSTF definitely has come forward several years ago and said women with certain family histories, and I should say men as well, can benefit from genetic counseling to learn about testing. Now that's been taken in a I believe out of context to mean, oh, if Sue Smith has breast cancer in her family, we should do BRCA testing. Absolutely not. What they're saying is it's enough to go get further information to determine whether or not testing would be advantageous in that situation. And then EGAP, and this is my new favorite thing, is that all people newly diagnosed with colorectal cancer should receive counseling and educational materials about genetic testing. But I'd like to see that go one step further. All newly diagnosed colorectal cancers should have MSI testing or mismatch repair testing on them to see could this individual and therefore their family be at risk for Lynch syndrome. So in the genomic health or the genetic testing environments, there's a lot of areas of concern, and one of them is access. As I mentioned, there's about 3,000 board-certified genetic counselors in the United States, and I don't have that slide today, but I do have a map, and it's basically in your large metropolitan areas, and if you look at, I'll try to do this right, so if you look at Michigan, and you look at where the genetic counselors are, there's this pocket of us over here in Grand Rapids. There's a couple in Lansing, not very many, and then there's a huge cluster over in the Detroit metropolitan area. But we have huge portions of our state that aren't covered per se by genetic counseling, and most states will hold true to those types of maps. And so what genetic counseling has done over the last few years has really transformed itself from both a face-to-face brick and mortar type of service to a telephonic telemedicine-based service, and they have looked at the results of those as far as what the processing of the educational information was from the patient's standpoint, as well as appropriate selection criteria, and they have seen very positive outcomes there. And so we have partnered ourselves with a very large organization that offers that to our members, and so any member, regardless of their location, can access genetic counseling services for Priority Health, and I know several other much larger payers than us have done the same, so we can increase access. Unrealistic expectations. There are a lot of unrealistic expectations, both at the patient level as well as provider level, as to what exactly this genetic test is going to tell us, and certainly, like all other areas of medicine, we just need to keep trying to educate that. There's very little gatekeeping associated with genetic tests. It falls under the category of home brew, and I like to call it the Sally Struthers School of Laboratory Development. It's very limited as far as what oversees the development of laboratories in genetics. A lot of labs will influence inappropriate ordering, the idea of, here, let me leave 25 kits for BRCA with you, and if you have any patients that have a family history of breast or ovarian cancer, just send us the sample. We'll make it easy for you. Well, I'm going to show you a few case examples where that's not necessarily a good thing, and certainly you're not, there's the idea of getting informed consent is quite limited in that situation. Lack of coding transparency. So I just added the red on this slide because I am super excited about the change in the last year and a half in coding for genetic testing. Before it was all stack codes, so 94989 times 50. So it didn't matter if you were having a test for CF, if they were looking at the genetic marker of your HPV virus, or if you were having BRCA, they were using the same generic lab codes in different stacks. And so just by the code alone, it was virtually impossible to know what's going on here. But that has changed dramatically. So we are able to control ordering of certain tests a lot easier now just by setting up the payment by code. If it comes up 81211, which is BRCA, you betcha, that's going to stop and look for a prior auth, versus that HPV, have at it. Don't care, let it go through the system, because that's not where we need to invest our time. And then policies, we do try to be proactive, but certainly they're not the be-all, end-all, and we're going to go into that some more here. So hereditary cancer syndromes, I know we've all heard of the biggies, but there are over 400 different genes associated with a variety of hereditary cancer syndromes, and we know that 5 to 10% of all malignancies are due to mutations in these genes. However, a mutation does not always necessarily lead to cancer, and we need to consider what else is going on. And one of the things that Ellen mentioned last night in her talk was she discussed the opportunity of having direct-to-consumer testing via 23andMe. However, we need to be cautious such that what they may be saying is you have a variant in X, Y, or Z gene, and now you are at twofold increased risk for pancreatic cancer. Well, if I'm not educated about what the incidence of pancreatic cancer is in the general population, that might be very upsetting to me. Whereas I personally can look at that, look at my family history and go, not so big a deal. So we need to be cautious of what a mutation may actually mean or not mean. And then on the right side, who am I? I have macrocephaly, so I have a big head. Facial papules, oral mucosa papilloiditis, and it's usually right in here. And then those lovely, strange-looking little white bumps. What am I? Who am I? I'm P10 Cowden syndrome. But how I got to this point was they presented with strong family history of breast cancer. They walk in my door, I look at their head and go, oh, let me get my tape measure. Because I instantly think P10. But I think in the hands of somebody that wasn't educated and they see a family history of breast cancer, they're going to see BRCA1 and 2, test, negative. Oh, we missed it. We missed a huge syndrome with significant implications to that individual and that family. So genetic testing is not just BRCA and Lynch syndrome anymore. I just put Ambry up there simply because they have a lot of good materials available on their website, but they certainly are not the only lab offering hereditary cancer panels, but they now have BRCA plus, which I believe is 6 to 10 genes where there may be some frequency of breast cancer associated with those genes. Breast Next, which is 20 genes. Cancer Next, which is pretty much every form of cancer that we can test. Colon Next, Ova Next, Pancreatic Next, PGL Next, and Renal Next. It's overwhelming to me, and this is what I do day in, day out, when I get a request, and I often get the Breast Next request is the most common one I've been getting. And I'm going, holy cow, you're testing for 20 things here. Let me see that pedigree. And I see a pedigree where there's some breast. Oh, there's an ovarian cancer. What else is going on? It doesn't make logical sense to me, but I understand from a provider perspective is, well, I didn't know I should look for a big head. So this way, I could just order everything and we'll see what we get. I'm not sure that's the best use of resources at this point. And these are being heavily marketed. So I think the benefits of utilization of genetic counseling are multifaceted or are multiple, but one of the biggest benefits is avoiding inappropriate testing. Not avoiding testing in general, just avoiding the wrong test. So what we want to do is make sure that the right tests are being given to the right patients. And here we have a situation where we have, actually, I could skip this one because Ellen she covered this last night very well, where there was failure to order a genetic test. Woman diagnosed with breast cancer undergoes unilateral mastectomy. Later on, has family history done, BRCA mutation found, and now she's undergoing a second test, or a second surgery, apologize for that. But studies have been shown that when we put the onus on the physician to determine which test, if any, should be ordered, that approximately only 19% of physicians ordering a BRCA test were able to correctly identify a low versus a high-risk scenario. 72% of non-genetics trained MDs rate themselves as having fair to poor knowledge regarding genetics. And certainly there's a lack of consumer preparedness regarding genetics and genetic testing. And this was another part, and this was all physician self-report of how comfortable they were with testing. Approximately half of individuals felt they could explain results, so that means half of them didn't even know what to do with results, and throw out variant of uncertain significance. And now we're all sitting there looking at each other going, that's pretty interesting. But we don't know what it means. So it's very difficult to choose the right test, as I already mentioned. What lab do I send the test to? Is this going to be covered by insurance? I had this discussion at length with a genetic counselor the other day, where she had sent in a request. I couldn't even figure out what test she wanted, but once I was able to determine that, I specifically asked her why she was choosing the particular lab she chose, and do you know what she said? Because the kits are in my office. And I said, well, let's have a talk about coinsurance. And so it's a matter of educating my fellow genetic counselors too, from a payer perspective and from a member benefit level. You know, the time has passed where we can just order from the most convenient lab. We need high quality labs, but we also need best price and high quality together. So ARUP in 2011 published a paper where essentially they were able, because they employed genetic counselors, they were able to determine through a test order as well as follow-up phone call to provider ordering the test that 33% of the time the wrong test was being ordered. 31% of tests were inappropriate altogether. 11% of tests involved sequencing when single panel was more appropriate, meaning there's already an identified mutation in the family, so we only need to look at single site versus full sequence. So this can be quite costly. Guidelines recommending the use of genetic counseling are from the vast majority of the major organizations. Now, you'll see words such as counselors are important, counselors should be involved. It's not a mandate, but it's certainly a recommendation for it. Now, I mentioned earlier that we have a collaborative agreement with the Michigan Department of Community Health and the CDC. The first phase of our project was simply to increase the awareness and the number of health plans within the state of Michigan that had a genetic policy to require counseling. And then we were the first plan to implement the requirement, not for all genetic tests, but for things such as BRCA, that you must have counseling before testing can be performed. And I believe the vast majority, over 90% of payers in Michigan now follow the same outline for coverage. What is the impact of a positive or a negative test on patient care? It can be huge. Should we increase screening? Or can we go back to general screening? The second phase of our collaborative agreement right now is we are looking at data of all of our members who had testing over a 1.5 year period of time, and we're looking at the screening that they had prior to the testing and the screening that they've had post-testing and correlating it to results, because what we want to see is, are our positive patients getting increased screening as recommendations require or suggest they do? And certainly of our true negatives, are they still getting increased screening as completely unnecessary? We haven't analyzed that data yet, but we have collected that data. The other things are, will this test be of any medical utility? From the idea of, am I going to change anything? And I know this isn't oncology related, but my favorite misused test of the day is microarray analysis for developmental delay. Developmental delay, microarray, oh, those are interesting changes. Developmental delay. There's no change from start to end point. We don't have changes in care, but we do have some interesting findings on their array. So we developed a policy, as I already mentioned, and we have the big, massive, giant policy when we've categorized that out into different areas of genetics. And then we have an overarching requirement associated with genetic testing, number one being appropriate counseling before and after testing. Informed consent, the state of Michigan has a specific informed consent law for genetic testing. Reasonable expectation that the condition for which you're testing is present. And then knowledge of the presence or absence of the condition would directly affect the medical care of that member. Aetna, Cigna, United, Humana, we're all in the same group here. We all follow the same general rules. Operationalizing, like I said, it's going to require a little bit of homework on your end. You're going to have to partner, most likely, with a telephonic genetic service to get full coverage. You will see, we saw, this is our from United, Aetna, and number 4 is a group, that's our provider of telephonic medicine, is Informed Medical Decisions, is that there was a reduction in requests. When I say reduction in requests, meaning I was denying tons of tests that were determined to be inappropriate. I hardly deny tests anymore because the requests I get are good requests. I believe that's because they've had counseling ahead of time. There is coding now. You can reimburse and bill for genetic counseling. I did want to mention, because I know there will be more discussion on genomic testing, somatic cell testing. What I've touched on in my talk is primarily germline testing, but genetic counselors definitely have the skill set to be involved in interpretation of somatic cell or tumor marker testing as well, because again, it's the same skill sets going on there. Policies aren't a complete solution, but if you don't have a policy, if you don't have a comprehensive policy, I highly recommend you get one. So the key points here are improved care, improved cost effectiveness, and then improve outcomes. So I will end there. If anyone has some questions? Okay, you're stunned and amazed. Thank you.